آه، الدكتور فيصل هو اي سي كونسلتنت في كينج عبد الله في مكة، وبيكلمنا من مكة. وادلت كريتيكال كير كونسلتنت، وكمان هو الدايركتور بتاع السعودي كريتيكال كير فيلوشيب تريننج بروجرام، وده منصب مهم جدا. وعضو في الناشونال انترناشونال ايكمو جروبس، وحاصل على شهادات كتيرة ومحطوطة في التقديم بتاعنا. اتفضل يا دكتور فيصل.
Assalamu alaikum wa barakatuh. Again, it's a pleasure to be between you tonight, inshallah. I'm going to present to you the hypertensive emergencies guidelines and best practice recommendation as published in Emergency Medicine Practice in June 2023. I will try to be concise, inshallah. I will try to finish within the dedicated time. Anytime, any questions, I am all ears. So, Bismillah ar-Rahman ar-Rahim. So, why this topic? So, what's the clinical challenges? So, first, what defines hypertensive emergency? Second, what are the most common and dangerous end organ dysfunctions to watch for? And how do the different society guidelines define and treat hypertensive emergencies? So first case, this is a 76 years old male patient brought to emergency department with his family who were concerned that he might have dementia. So the family informs you that he is normally a sweet old man, but recently have been having episodes of confusions and agitations. Yesterday, the police found him walking along the highway in his bathrobe. So his family brought him to the emergency department that mentioned to you that he has a history of diabetes and hypertension. They don't know if he was been taking any medications other than this, and what are exactly his medications. So on examination, his temperature was 37, blood pressure was 236 over 113, heart rate was 62, respiratory rate 14, and oxygen saturation maintained in room air, blood glucose level within normal range. So on examination, you found him alert, oriented to name only. He complains of a headache all over, seeing strange flashing lights, and is annoying. Start to be annoyed by your continued questioning. So as you continue, he no longer participates in the physical examination and begins to have jerking movements. So at this point, which medication should you use to treat him? Second case, a 59-year-old woman presented to the emergency department after being seen by at her primary care physician office. So the doctor was concerned because her blood pressure was 206 over 120, and the blood pressure normally runs high, but not this high. So the patient stated that she feels fine. She denies any vision changes, any headache, any chest pain, any shortness of breath. Past medical history is relevant for hypertension and prediabetes. She states that she didn't take her oral her blood pressure medication this morning, since her primary care doctor told her not to drink or eat anything prior getting to the clinic for laboratory workup. So you wonder whether anything needs to be done in the emergency department about her blood pressure. So just this is a reminder for the definition of the hypertension based on the American and the European guidelines societies. So the American, they define the hypertension grade 1 if the blood pressure systolic more than 130 to 139, and grade 2 if more than 140, while in the Europeans, they start from grade 1 as 140 to 159, grade 2 from 160 to 179, and grade 3 from beyond 180. Hypertensive emergency is a clinical syndrome significantly elevated blood pressure associated with rapidly progressive end organ damage. It's associated with significant morbidity and mortality. And the terms of hypertensive urgency, hypertensive crisis, and malignant hypertension all are historically defined as severely elevated blood pressure without evidence of end organ damage. With some variability from study to study, severe hypertension defined as systolic blood pressure more than 180 or diastolic more than 110. For this review, they conclude that blood pressure of more than 180 over 110 or MAP of more than 135 will be used to define severe hypertension. So critical care appraisal for this literature. So they conclude more than 5,000 articles were screened, and 122 articles were included in this discussion between the years of 2020 and 2023. Among all hypertensive emergencies, the strongest evidence to guide optimal blood pressure management is for patients with intracranial hemorrhage. The American Heart Association, American Stroke Association, and the European Stroke Association guidelines reference the ATTACH and the INTERACT trials as high-quality randomized trial that gives the clinician strong evidence for specific blood pressure targets. So other hypertensive emergencies, such as acute coronary syndrome, have no well-designed clinical trials to direct optimal blood pressure management, and therefore the recommendations differ widely between guidelines, different guidelines. The American Heart simplify the hypertensive emergency management by reducing the blood pressure with a maximum of 25% in the first hour, followed by a target of 160 to 110 over the next 2 to 6 hours for all hypertensive emergencies except aortic dissection, preeclampsia or eclampsia, and pheochromocytoma crisis. This is just a table to summarize the hypertensive emergencies which require immediate blood pressure lowering. I will skip this if you allow me. Again, this is the etiology and pathophysiology. Most of us know this well. Different organs contribute with the hypertension, causing it like a vicious cycle, starting from the heart, from the adrenal with the secretion of the aldosterone leading to salt and water retention, to the kidneys causing the renin system and decrease sodium excretion, increase the water reabsorption. Again, to the liver through the release of the angiotensin 1, and the lung with the activation to the angiotensin 2, which is a potent vasoconstriction, and this will lead to vicious cycle, more hypertension, more release of these hormones, again more hypertension, and so on. So you need to till you break this cycle. This is the differential diagnosis of hypertensive emergencies. Like at the level of the brain, you need to look for hypertensive encephalopathy, posterior reversible encephalopathy syndrome or PRES, acute ischemic stroke, subarachnoid hemorrhage, intracranial hemorrhage, or hypertensive retinopathy. At the level of the arteries, you need to look for the aortic dissection, preeclampsia or eclampsia or HELP syndrome, thrombotic thrombocytopenic purpura. At the level of the kidney, you need to look for acute renal failure or scleroderma renal crisis. At the level of the heart, you need to rule out myocardial infarction or congestive heart failure. Substance abuse like endocrine, Cushing, and pheochromocytoma, and others. So what you need to look for in the physical examination. So first, they recommend here MAP is often the preferred measurement of the blood pressure for several reasons. Why? The autonomic, the oscillometric blood pressure cuffs, usually they measure MAP, and they calculate the systolic and the diastolic blood pressure based on the MAP reading. Secondly, the systemic autoregulation adapts the changes in the MAP. So this is the second reason you need to adapt MAP rather than systolic or diastolic. Third, titration of antihypertensive medication based on a single number, which is the MAP. It's more reliable than using diastolic or systolic blood pressure. But unfortunately, most of the society recommendations described in this review do not use the MAP as a single number or single predictor. So lungs heart auscultation should be performed looking for any sign of congestive heart failure or pulmonary edema. Evaluation of the abdomen looking for any bruit or mass that can suggest renal artery stenosis or aortic aneurysm. This is the most common presenting symptoms in hypertensive emergency: shortness of breath, almost 30%, chest pain, like 26%, headache, 23%, altered mental status, 20%, and focal neurological deficit, around 10%. And the most common sequelae of hypertension-induced end organ damage, if this is not treated, if these symptoms are not managed well, they will end up with a pulmonary edema or heart failure in 30% of cases. Ischemic stroke, almost again 30%. Acute coronary syndrome, 18%. Hemorrhagic stroke, like 11%. Acute aortic syndrome, mainly dissection, 2%. And hypertensive encephalopathy, again 2%. Traditionally, the suspected patient with suspected hypertensive emergency, they should undergo for fundoscopic examination, looking for grade 3 or 4 hypertensive retinopathy, which can be the only sign of end organ damage. So what you will look for in grade 3 or 4, you can see the cotton wool spots, the flame-shaped hemorrhages or papilledema. Unfortunately, currently no guidelines or there is no statistically significant evidence to suggest whether all patients being evaluated for hypertensive emergency require fundoscopic examination. This is a BARKH-based algorithm. This is proposed from the Department of Medicine Emergencies and Hypertension Unit in Italy. And they adapt this algorithm and the acronyms for this algorithm like brain, arteries, retina, kidney, and heart. So in this algorithm, they start first with the grade 3 arterial hypertension, with, as I mentioned, systolic more than 180 or diastolic more than 110. So they look for evidence of BRAC, which either brain, looking for stroke or hypertensive encephalopathy. At the level of the arteries, they look for acute aortic syndromes or preeclampsia or HELP. At the level of the retina, they do, in this protocol, they have to do a fundus exam for all patients, looking for grade 3 or 4 hypertensive retinopathy. And the kidney, acute renal failure or thrombotic microangiopathy. At the level of the heart, they're looking for heart failure or pulmonary edema. If any of this is present, they define this as hypertensive emergency, and they produce and they start rapid blood pressure reduction based on their algorithm. I will mention it later. So what diagnostic studies you should look for? It's well documented and evaluation well documented that evaluating for end organ in asymptomatic patient does not change the emergency department management, nor does it improve outcome. So if the patient is asymptomatic, you don't need to look for something which is not there. It's waste for your time and for the patient time. So it does, however, increase the likelihood of unnecessary hospitalization. This is a well-known fact. And patients who have presented with the blood pressure more than 180 over 110 without signs or symptoms of possible underlying hypertensive emergency shouldn't be subjected to routine diagnostic studies in the emergency department based only on their hypertension alone. Sorry. Other lab like CBC looking for evidence of microangiopathic hemolytic process. LDH again could be the only sign of, and heptoglobin could be the only sign of hemolysis. Point of care glucose to exclude hypoglycemia. If you have a concern of myocardial injury, you can consider asking for cardiac troponin. Basic baseline ECG if you have concern of myocardial ischemia with the classic strain pattern as ST depression, downsloping convex ST segment, and discordant T-wave inversion in the lateral precordial leads. Imaging study like chest X-ray, which is useful. It can, for the anterior pulmonary edema, cardiomegaly, or even widened mediastinum, which can give you a clue of aortic dissection. Point of care ultrasound, looking for again aortic dissection, evidence of left ventricular hypertrophy or diminished ejection fraction, or even part of POCUS you can assess for pulmonary edema. CT of the head, very useful to exclude the intracerebral hemorrhage and or ischemic stroke. And when done within 6 hours, it will be the golden standard image for subarachnoid hemorrhage with a negative predictive value of almost 99%. This is the classic or the classic presentation of hypertensive intracerebral bleed. Can be in the putamen, can be in the thalamus, subcortical, or in the temporal lobe, cerebellum, or pons. This is the classical hypertensive bleeding sites in the brain. And this is the high signal intensity vasogenic edema on MRI, as you can see here, which is specific for the posterior reversible encephalopathy syndrome. Again, you can use the fundus, the ocular ultrasound assessing the optic sheath diameter and optic nerve sheath diameter more than 5 millimeter could be the only indicator of papilledema and sign of elevated intracranial pressure. So what I will focus here on fastly on the management of acute decompensated heart failure. acute ischemic stroke, acute coronary syndromes, intracerebral hemorrhage, subarachnoid hemorrhage, hypertensive encephalopathy, aortic dissection, severe preeclampsia or eclampsia, and acute renal failure. And again, here I will mention what have been mentioned in the guidelines, whether European or American guidelines. So I'll start with the acute decompensated heart failure. So first, in the treatment of hypertensive acute decompensated heart failure, you focus on both lowering blood pressure and improving respiratory distress. So the three elements you need to focus on in managing hypertensive acute decompensated heart failure: non-invasive post-pressure ventilation, diuretics, and vasodilators. So the diuretics, the post-hoc analysis, very interestingly, this is a large multi-center prospective registry of the Reality Acute Heart Failure Registry, showed that a threefold lower hospital mortality if the patient received any dose of IV furosemide within 60 minutes of arrival, compared to those who received Lasix or furosemide later, after 60 minutes. And there was also no standardized dosage. There is no recommended standardized dose of IV furosemide in all guidelines. But usually the European in 2021 and the American in 2022, they recommend using loop diuretics for patients who have signs of volume overload, which makes sense. And the general recommendation is almost 1 to 2 times of the patient's equivalent oral dose of loop diuretics. Next is the vasodilators. Multiple large systematic reviews and RCTs demonstrated that the use of vasodilator agent safe and effective in lowering the systolic blood pressure, but most of these RCTs fails to show any consistent improvement in short or long time survival. So administering high-dose nitroglycerin followed by continuous infusion of nitroglycerin titrated down based on the symptoms improvement and target systolic blood pressure have been shown to be safe and maybe reduced the incidence of ICU admission. A systematic review found with a moderate quality evidence that high-dose nitrate may lower rate of mechanical ventilation, improve blood pressure, shorten length of stay, and lower rate of ICU admissions. Other treatment like morphine, in most of the guidelines, shouldn't be used and should be avoided. Why? Because it has 5-fold increase estimated mortality risk if the patient receives morphine. Nisiretide, which is a recombinant human natriuretic peptide. Again, most of the guidelines based on the ASCEND heart failure trial, which is a large double-blind RCT, they showed no clinical benefit and associated with significantly associated to cause more hypotension. So what is the blood pressure target in the acute decompensated heart failure? The European and the American guidelines do not mention any specific target for systolic blood pressure. A post-hoc analysis of the Reality acute heart failure study reported that patients who have reduction in the systolic blood pressure more than 25% have higher mortality. So based on this, they conclude that it's reasonable to lower your blood pressure or systolic blood pressure between 10 to 25%, not more than 25% with hypertensive patient who present with acute decompensated heart failure. Next is the acute ischemic stroke. So a treatment should be guided whether the patient will receive thrombolytic medication or mechanical thrombectomy. So if the patient is going to receive thrombolytic therapy or mechanical thrombectomy, the American and the European guidelines recommend lowering blood pressure to less than 185/110 prior giving an intervention, and to keep it below 180 to 105 for the next 24 hours post-intervention. For patients who are not receiving any intervention, either thrombolytic therapy or a mechanical thrombectomy, there is no strong evidence to identify an optimal blood pressure in the first few hours. So they conclude if the patient has blood pressure more than 220/110, both the American and the European Society to decrease the blood pressure not more than 15% would be a reasonable approach. Beyond this can cause worse outcome. And regarding elderly patients who are beyond 70 years, more than 15% significantly associated with worse outcome, especially in this age group. Next, acute coronary syndromes. So blood pressure targets, again, during the acute stage of acute coronary syndrome, there is no good data to suggest an optimal blood pressure target, either from the European or the American. The European guidelines specify a normotensive target in non-STEMI, while the American Heart do not commit at all for any target blood pressure. Multiple large prospective studies have shown lower in-hospital mortality and reduced major adverse cardiovascular event for those patients who present acute coronary syndrome with hypertension. They have better outcome. And the American Heart and the European for STEMI management guidelines recommend that systolic blood pressure more than 180 or diastolic more than 110. This is a relative contraindication for fibrinolytic therapy. And you should be very cautious as blood pressure frequently fluctuates in early stages of acute coronary syndrome. And 190 suddenly, it depends on the myocardial function. So if it drops, the blood pressure will drop suddenly. So you need to be very cautious in this kind of patient. The use of beta blocker, the American Heart and the European Society guidelines recommend administering a high beta-1 affinity like metoprolol for all hypertensive patients present with STEMI, that's a class 1 level A evidence, or oral, which is class 2A with level B evidence for IV administration. And the multiple RCT have demonstrated that the beta blocker can reduce myocardial infarction, the risk of ventricular fibrillation, and decrease the infarction size. The European Society conclude that only acute decompensated heart failure, hemodynamic instability, or high degree AV block as a relative or as a contraindication for beta blocker use. And they recommended to lower blood pressure slowly and avoid the systolic less than 60 to maintain coronary perfusion. Nitrates, both the American and the European guidelines recommend IV nitrates for hypertensive patients with non-STEMI. Unfortunately, for the use of nitrates in acute coronary syndrome, both guidelines studies conducted more than 20 years ago. So there is no RCT in the last 20 years to clarify whether nitrates therapy improves mortality in this kind of patient. Next, the intracerebral hemorrhage. So the blood pressure target, both the American and the European guidelines recommend immediately lowering systolic blood pressure to less than 140. As I mentioned earlier, the strongest evidence for blood pressure targets is in the intracerebral hemorrhage group. The largest RCT is the INTERACT-2 and the TOUCH-2. They put two groups. One group was cubic systolic less than 140 or less than 180. The second group, and they found every 10 millimeter mercury reduction from 170 in the systolic blood pressure associated with lower mortality, smaller hematoma expansion, and better functional recovery. And they found that there is statistically significant reduced overall neurological deterioration if the blood pressure was maintained between 120 to 130 systolic blood pressure. Clinician should be very careful because the highest risk of mortality in the first 6 hours, it is caused by, unfortunately, by iatrogenic hypotension. So you need to be very, very cautious not to be to introduce a high risk of mortality, which is overshooting and overtreating your systolic blood pressure in this kind of patient. So what antihypertensive medication you can use? The American and the European Society guidelines do not mention any specific antihypertensive to use, and recommend using just they need to be fast and short half-life. For this, both nicardipine and labetalol effectively and safely reduce systolic blood pressure in patients with intracerebral hemorrhage, with no clear evidence that suggests one works better than the other. Either nicardipine or labetalol is a reasonable first choice. Whatever you have, whatever in your hand, use it. A small pilot study demonstrate the efficacy of clopidogrel, a new generation of calcium channel blocker, to reduce systolic blood pressure. But other studies have found no difference in the time, no difference in the length of stay or overall outcome compared to nicardipine. Next, subarachnoid hemorrhage. In aneurysmal subarachnoid hemorrhage, the focus primarily is for prevention of rebleeding in the first 12 hours. And the American guidelines recommend lowering systolic less than 160, while the European, they recommend systolic less than 180. No specific antihypertensive agent is mentioned again in these guidelines. And unfortunately, there is no data to guide treatment in patients with non-aneurysmal suprapulmonary hemorrhage. Aortic dissection, to date, there have been no RCT evaluating specific blood pressure targets during acute management of aortic dissection. But in 2022, the American guidelines recommend reducing the heart rate between 60 to 80 and systolic less than 120. While the European guidelines, they recommend using IV beta blocker for simultaneously lowering the patient's heart rate and systolic blood pressure. They recommend the vasodilator can be used in including nicardipine, clevidipine, and nitroprusside. Hypertensive encephalopathy. Hypertension most commonly seen if the blood pressure more than 220 over 120. There is no RCT to suggest a specific goal in blood pressure reduction or which antihypertensive agent to use. The International Society of Hypertension guideline recommend immediately reducing the MAP by 20 to 25% using nicardipine or labetalol. If you have PRES, which is the posterior reversible encephalopathy syndrome, remember that PRES can happen in hypertensive, normotensive, or even hypotensive patients, so you consider look for another reason. Severe eclampsia or severe preeclampsia or eclampsia, the American College of Obstetrician and Gynecologists, they recommend hospital admission for women who present with 20 weeks after 20 weeks gestation, who have preeclampsia with severe features. They define this as systolic blood pressure more than 160 or diastolic more than 110, confirmed by two readings 15 minutes apart, or two readings more than 140 over 90, 4 hours apart, associated with thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, or new onset headache. So for this kind of patient, you need to decrease the blood pressure to less than 140 over 90, because beyond this, associated with the worst outcome for the pregnant and the baby. So what antihypertensive you use? The American guidelines, they recommend either labetalol, hydralazine, or oral immediate release nifedipine as a first line therapy. But later on, there is 21 trials, meta-analysis of 21 trials compared hydralazine to other antihypertensive. They found hydralazine associated with more maternal hypotension and placental abruption. So it's better to use other than hydralazine for either nicardipine if you have nifedipine oral or labetalol. And they recommend magnesium sulfate, a loading dose of 4 to 6 gram, followed by 1 to 2 gram infusion for seizure prophylaxis. Remember, if you are on magnesium sulfate infusion, you need to assess for deep tendon reflexes and respiratory status continuously. If your patient present with acute renal failure, the International Society Hypertension Guideline recommend using either nicardipine or labetalol. As you can see, most of the guideline, they recommend either nicardipine or labetalol as a first-line antihypertensive agent. So reducing the systolic blood pressure, again, shouldn't be more than 25%. But please, if the hypertensive emergency is suspected the cause of acute renal failure. If you remember the slide which I mentioned earlier, the pathological or the sequelae of hypertensive emergencies, the acute renal failure, it's not one of the common sequelae of hypertensive emergencies. So if you have acute renal failure, look for other reasons before you label this as hypertensive emergency related acute renal failure. I hope this message clear. So controversies and cutting edges. So do we need an arterial monitoring? So putting an arterial line, is it necessary? So in this review, they found that it is unnecessary to put an arterial line. Why? First, because of the pain, which is can exacerbate the hypertension, and there is no prospective evidence to show that this procedure will be of beneficial or necessary. And currently, the blood pressure targets still mostly arbitrary and poorly defined, with the exception of intracerebral hemorrhage and ischemic stroke. So based on this guideline, they don't recommend, or it's unnecessary to put an arterial line only for hypertensive emergency patient. The use of beta blocker in cocaine-induced hypertension. Maybe most of you know that there is theoretical risk of unopposed alpha adrenergic stimulation when used beta blockade in conjunction with cocaine use. But to date, the only statement that the unopposed alpha stimulation after beta blockade in cocaine toxicity is inconsistent, unpredictable, and it's a rare phenomenon. So where this patient should go, the American task force recommend all patients with hypertensive emergencies should go to ICU for continuous monitoring and parenteral administration of antihypertensive agents. Patients presenting to the emergency department which do not meet criteria of hypertensive emergency can be safely discharged with outpatient clinic follow-up for management of blood pressure with oral medication. This is the summary of medication to be used and dosage and what is the maximum dose duration of action. I'll skip this. This is the proposed pathway. So if you have a patient with grade 3 hypertension, as we mentioned, MAP more than 135, systolic more than 180, or diastolic more than 110, first thing you do the BRAC algorithm. If you don't have any of the BRAC algorithm there, so no indication for blood pressure monitoring reduction, consider discharge or the primary care follow-up. If you have the BRAC is positive, one of them is positive. So first thing is there a potential secondary cause of the hypertension? If yes, you need to treat the underlying cause like alcohol withdrawal or pain or whatever the other reason. If no, this is hypertensive emergency, treat the underlying cause as we mentioned in the previous slides. So risk management pitfalls for hypertensive emergencies in emergency department. So the first question, the patient should be normotensive. So this statement, I know most of you will agree, this is a false statement, as treating hypertensive emergency too aggressively is as dangerous as failure to treat. So normal blood pressure may lead to hypoperfusion in patient chronically elevated blood pressure. So try to avoid treating numerical values. So we had difficulty getting IV access. So we started on oral medication. Is it acceptable? No, it's not acceptable. Using oral intramuscular or intranasal medication to treat hypertensive emergency is inadvisable as they are not easily titratable. As I mentioned, most of the guidelines recommend short-acting, titratable, and parenteral medication to avoid treatment errors, dose stacking, or poor patient outcome. We need a second agent to control the pressure. If you ask yourself this question, please, before you go ahead and add a second antihypertensive agent, please rule out these confounders like pain, agitation, substance withdrawal, or urine retention. If any of this is there, whatever antihypertensive medication you will add, your patient will be still hypertensive till you correct these factors. And once you correct this factor, if you are already on high dose, two medications with high doses, you will find your patient blood pressure drop significantly. So try to rule out these factors before adding second antihypertensive agent. At first, I treated systolic blood pressure, but then I realized that the systolic pressure was too high. For this reason, using MAP can cause not using MAP can cause inconsistencies in treatment, leading to treatment errors. This allows for dosing antihypertensive titrated against a single variable. So some of you will use the systolic, some of you will use the systolic. So attempting to titrate antihypertensive infusions with systolic and diastolic simultaneously can lead to overshooting your blood pressure targets. Metoprolol is a beta blocker, just like labetalol. Most of you know this, that metoprolol is a selective beta-1 receptor blocker. And unlike labetalol, which is non-selective beta blocker, has some alpha antagonist effect. So remember, metoprolol has very little role in the treatment of hypertensive emergency. She was having hypertensive emergency, fluids will only make it worse. Again, this statement not true. So not considering volume depletion as a cause of hypertension, as we all know, hypovolemia will lead to renin angiotensin system activation, sodium excretion, and more hypertension. So the bedside ultrasound and assessment, volume assessment, very important to assess the intravascular volume and giving fluids accordingly. The blood pressure was better after an hour, so I gave him oral medication. Is it acceptable? Of course not. So remember, blood pressure and the transition from IV to oral agent can be dangerous. Treatment of hypertensive emergency should be gradual, at least, yeah, to step this not beyond 24 to 48 hours after reaching your blood pressure targets. So why didn't my middle-aged white female patient respond like my chronic hypertensive elderly black male patient? Remember, there is strong evidence that ethnicity, sex, age all play a large role in an individual's response to different medication. Consider this factor when choosing proper agent for antihypertensive for management of hypertensive emergencies. So back to our case, I will remind you this is the elderly man who present with high blood pressure and then start to have jerking movement. So he was given IV lorazepam for the seizure, and you ordered CT brain. CT appeared to be normal. So you performed a bedside ocular ultrasound, which showed evidence of papilledema, which raised the concern of cerebral edema. MRI requested, which showed the evidence of press, and he was started on nicardipine infusion. Second case, the 59 female who present just because her blood pressure was to 6/120. You concluded, you obtained an extensive past medical history. You concluded full assessment to look for any signs of end organ damage. And the patient was negative for all of this. She was discharged home with close follow-up for primary clinic. And I hope with this I conclude my talk for today. I hope I am on time. And this is the barcode. If you can, if you want, you will find the full review with this barcode. If you can, if you want to review it, the tables, the algorithms, all mentioned in the article. You can scan this barcode and you will find all the details you want. Thank you so much.
شكرا جزيلا دكتور فيصل. المحاضرة concise و extensively reviewed all aspects of hypertensive emergency with different end organ affection. And الحقيقة the best part was last few slides with pitfalls which important really. نشكر الدكتور فيصل مرة أخرى، وإذا كان حد من الحاضرين يحب يعلق أو يسأل فليتفضل، عشان لو ما كانش هو عنده ارتباطات فممكن within 5 minutes نبتدي المحاضرة التانية. حد يحب يسأل الدكتور فيصل؟ يعني المحاضرة الحقيقة كانت واضحة، ويعني ماسك الريفيو بالتفصيل، فما سابش حاجة. وإحنا بنعمل تقليد في الجورنال كلاب إن المحاضرات بنحطها على موقع في اليوتيوب اسمه حسن خالد جورنال كلاب، بحيث اللي يحب يراجعها تاني بيقدر يشوفها، زائد انت حطيت الكود اللي يقدر ياخدوا منه الريفيو بالكامل. والناس بتشكرك على الشات.
Again, it's a really pleasure to be with you today. I hope I added benefit. وجزاكم الله خير على المجهود اللي تقدموه للجميع، وإن شاء الله ربنا يجعله في ميزان حسناتكم جميعا إن شاء الله.
طيب وحد بيسألك can we have the QR code activated؟ هو مش activated، انت مش قلت ممكن يدخل عليه يشوف على طول؟
Let me check if it's activated. I will check again from my mobile. طيب I will send it through. It is
ابعته لعادل وانا اعمل لهم موقع على الواتساب هبعته لهم.
تمام. انا دكتور عادل يوسف.
لو عندك وقت احنا بنعمل محاضرة للفيلو، هو بيقول بيقرا مقالة حديثة ويلخصها. فالفيلو عندنا في اسم حالة حرجة في القصر العيني هيقول محاضرة عن ازاي الفلويد او بالفلويد تشالنج بريدكت سيستميك كونجيشن. فلو عندك وقت تتشرف تحضر معانا.
اكيد ان شاء الله. شكرا جزاكم الله خير.
اخرج بقى من الشير سكرين عشان